Good afternoon, everybody. Let's make a start then. We have one of the speakers who's a little bit late. I'd like to thank the organizers of ATHS. And it's with great pleasure that I'm able to preside this afternoon session. We're going to travel this afternoon. We're going to look at Australia, Lebanon, Ukraine, France, where we'll talk about reducing risks. As you know, it's a problem that's existed for many years now, and there was a new decree that came out recently, which has just been applied, which has just come into force. So, Gabriele FISCHER, who is the addictologist from the University of Vienna, and which is both a renowned international and national institution. Gabriele, over to you.
Thank you so much. Well, first of all, I have to turn off my interpretation for a moment. Thank you very much. Thank you so much, Fadi, for putting this together. And I'm a psychiatrist. I'm the head of the addiction research at the university, but I'm also a human rights person, and I have been working with the Human Rights Commission over the last decades to visit prisons in many countries in the world, also in Australia. And I bring you just an overview how important it is to have a diagnosis and the proper treatment in prison, next to some studies we did in prison. Is this? Yes, you can read. This is my disclosure because the studies were partly supported by pharmaceutical companies, Shire, Gilead, and MSD. Otherwise, I have no conflict of interest. I assume that you all are involved in prisons work, mostly in the health area, and we know that the prison could be a window of opportunity to treat disorders. We also face the limitation facts that adequate diagnosis and treatment is related to money, and it varies a lot between the countries whether the prison health facilities are supported by the Ministry of Justice, by the Ministry of Health, or other regulatory bodies, and it's very difficult to convince the public that it's important to invest money for patients, I say patients in prison, as we are aware of that about 70–75% of the persons in prison to have a psychiatric diagnosis. And if we support treatment in prison, it's going to be after release a public health issue. Just an example I give you with the two studies. If we diagnose and treat ADHD, attention deficit disorder, and if we properly diagnose hepatitis C and treat them. I think the audience is aware of the human rights treaties, that there are the Nelson Mandela rules. The Nelson Mandela rules show the principle of equivalence of care, as anybody outside the prison should receive the same medical care in the prison. Doing studies, doing research is a very tricky issue in prison, and this varies from continents to continents. Like Adrian DUNLOP from Australia, they learned us how nicely the depot Buprénorphine works in prison in a research study condition, which would be very difficult in Europe, because in Europe we are not supposed to do any medication treatment trials in prison. What I'm guiding you through, we did some diagnostic trials in prison, which was difficult enough. There are, next to the Nelson Mandela rules, there are other human rights treaties, and just point to the Convention on the Rights of Persons with Disabilities. If we go for unannounced visits to prisons, we keep talking to psychiatric sick patients, and we tell them that the Convention on the Rights of Persons with Disabilities is applicable to them. But it's very difficult to convince them, because in their head, and very often also in the head of prison guards and other people there, being the Convention relates to somatic handicapped person and not to psychiatric or mental handicapped persons, which of course is wrong. They are also included in the CRPD, which shows the special ethics situation that has to be considered for this group of patients. I refer also to the Convention Against Torture. All countries who ratified the CAT protocol know that torture does not only mean physical pain. Torture also relates to psychological pain. If somebody is in prison, it's the violation of the human rights, and it has to be announced to the public authority. And one special human rights covenant I really favorize. If we are in prisons and we look what kind of treatment is administered, what kind of psychiatric treatment is administered to the patients, in the Covenant on Economic and Social and Cultural Rights, it's indicated that everybody has to have access to the highest standard of science. So if we have the option of administering, for example, HCV treatment, what is not new anymore, it has to be delivered to the prisoners with hepatitis C, and ignoring the fact that it used to be very expensive some years ago, we know that it's much cheaper by now. And there are numbers of human rights treaties. They can't be administered for psychiatric patients in prison. I just refer to the key points for me. If we go to prison and look into the human rights situation of prisoners. In the case of opioid treatment, there are many publications showing the positive outcome of all different kind of opioid maintenance, initiated in prison, and also being aware, and we had this in the auditorium now, that very often patients are going to be released on Friday afternoon to make sure that the treatment is made available after discharge in order to prevent the high mortality rates in this situation. These slides, I think this is kind of frustrating. If you look into common knowledge that opioid maintenance is the standard of care in prison, and if you look into global data released from WHO, and the first column, I don't know whether you can read this in the back, is referring to the availability of opioid maintenance treatment in prison, and the pink column gives you where more than 50% of the prison have this kind of treatment. And the green column gives you the information that there is no information available. So still globally, we have to advocate and we have to raise the point that opioid maintenance treatment is saving life, and it has to be made available for the patients. Germany was sentenced by the European Court of Human Rights. If we think about being sentenced by the European Court of Human Rights, we would not pinpoint first place Germany. But this was one of the reasons, and I only have unfortunately the German version here, but Ikro Marimani published this in his journal, that there was a case, a male patient was reduced from methadone, and it was not accepted that he needed to have a certain maintenance dose. So Bavaria, the case in Bavaria, was sentenced actually for torture, not providing the adequate treatment in these patients. And I keep finally giving you some information on the research we did in prison. In this study, which is called ESCAPE, we looked into hepatitis C, ADHD, and psychiatric comorbidity in two groups. One, in adult inmates who were in 6 Austrian prisons being maintained on opioid maintenance treatment. And then the other group was the group of adolescents. We do have in my country, as in many others, if you're older than 14, you can be put in prison if you for crime, and we have special prisons for adolescents, which means minors older than 14 until the age of 24. So in these two cohorts, the adult cohorts being maintained on opioids, and the younger cohort just being in prison because of some crime. We did a comprehensive interview. I'm not going to be going into details. I don't know whether Adrian is talking about his trial, but we faced a lot of problems because the prison environment was not happy to do a research study because it was so much time consuming for them, and we had the need of having a confidentiality situation with their prisoners, for us the patients, and not being out of security reasons watching through the window, but being not exposed to any verbal information. And our ethics commission interestingly said, in our country, if somebody is voluntarily enrolled in a research protocol, gets money. So we also have to provide some financial support to prisoners, what was not taken up very nicely by the authorities. But nevertheless, it was the principle of being treated compared as if you would not be in prison. And we also did some HCV investigation with blood drawing. And I just want to mention it here. HCV is not only investigated if you once draw blood and find antibodies. You have to have a certain structure in order to reveal if somebody is not only antibody positive, but still is having the virus. This shows you the cohort of 133 adult opioid maintained prisoners compared to 71 young adolescents in prison. And the sample characteristic shows in my country, in all the prisons, we have all the opioid medication. In the study period, we did not have the depot yet, but we also have the depot medication. But if you take a closer look, it's nice to say that all of the opioid medication is available. It's not so nice if you look at the mean dosing of the medication. Because if you look into methadone, for example, 45 milligrams per day is much too low compared to the average dosing. Or Buprénorphine, 6 milligrams is just nothing compared to the average dosing, what keeps people in treatment. So the first, what my country is very proud of, that it's accessible to all of the prisoners, but there is a limitation of the mean dosing would be required. And if you look closely, you'll find that 50% have antidepressants, 52% have antipsychotics, and 85% have benzodiazepines of this cohort. And unfortunately, and our goal was to look into ADHD, only 3% had ADHD medication. And this was one person, it was on a non-stimulant medication. And we were asking why. Why do we have such a high benzodiazepine prescription, such a low mean opioid dose and no ADHD medication? Because nobody is being assessed for ADHD. This information you find in the dark columns. You find the opioid maintained clientele. In the light one are the adolescents and the young adults. And you find what we all know who work in prison on a standardized evaluation. we find the high psychiatric comorbidity in this group. We find a high depression rate, but the second column tells you the high suicidal risk in this population. So we find on a structured basis an underdiagnosed and an undertreated clientele. This all you can read in this publication, and I think the presentations are being made available for you. Why is it important now to look into ADHD, to diagnose ADHD? I think it's you know it's a clinical symptomatology what makes life very, very difficult for patients because they cannot concentrate, and one of the characteristic features is a high impulsivity. And ADHD is closely related to many psychiatric disorders. 50% do develop later on a substance use disorder. ADHD is highly, if we look only into ADHD investigations in prison, it's highly prevalent, about 25%. It's not a huge publication list what is made available, have in a meta-analysis the diagnosis of ADHD in prison. And why is it important? It's important because their increased impulsivity is very often related to increased administrative penalization. So they face longer incarceration periods, higher periods of penalization, longer periods of being restricted from a lot of benefits in prison. So that's very, very important. And just to illustrate to you now on this graph, how is the situation on childhood ADHD in the opioid-maintained population? They score 50% childhood ADHD, 17% of adult ADHD. But this is in a group of opioid-maintained patients who already have a basic dopaminergic release through the opioids. So it's and if we look into the younger, the adolescent group, 45% versus 10%, and if you compare it to the general population, in the general population we have a rate of 5% childhood ADHD and 3% adult ADHD. So it's a significant increase of ADHD. It's not enough, and that's the main message, it's not enough to diagnose substance use disorder. It's not enough to administer opioid maintenance medication. It's not enough to have the adequate dosing. It's very important, and my assumption is that the high benzodiazepine prescription is related to ADHD, which does not actually treat this disorder. We all know on the high benzodiazepine dosing how the patients are behaving. So it's a significant rate on ADHD even in an opioid-maintained population. And I just mentioned this, these clientele who had an adult ADHD had early onset of substance use and in all substances with the exception of hallucinogenic drugs. And I keep on because I look at the time. I finish with my...
17.
Okay, 3 minutes, good. So finally, in the same sample, we investigated HCV. HCV is highly prevalent because we know the environment, even not only people with HCV come to prison, but people acquire HCV in prison. So it's very important to have the proper assessment. And on this graph you find, like many patients say, well, I had hepatitis C, I'm totally fine. But experts know we have several subtypes. So despite the fact that they have been treated for one subtype and have antibodies, they can still have an active hepatitis C with another subtype. And I think that's, to keeping the time, I'm closing my presentation with these slides showing that 74 had antibodies against hepatitis C, but still 45% had an active infection. So it's very important to have a standardized analysis of the blood, which again is not very easy in prison situation, despite the fact that in the Human Rights Treaty, CAT, and the countries who ratified this, it's indicated they have to check for infectious diseases, but it's not a blood drawing for one time. You have to follow the algorithm in order to detect it. Thank you so much for your time.
Thank you very much, Gabriele. Thank you very much, Gabriele, for this presentation. Do you have any questions that you'd like to ask, Gabriele? You said, Gabriele, that 45% of prisoners had this disorder or attention disorder. Do you think that if we had a more effective treatment on addictions, there would be less attention disorders? What leads to these attention disorders? Do they lead to addiction, or is it the reverse?
They have a common pathway because it's a disturbance on the dopamine transporter to develop ADHD. And if you develop ADHD and you're not diagnosed, you have a high overlap with substance use disorder in the kind of self-medication. And then we have a double diagnosis, not only ADHD, which seems not to be known, but the substance use disorder is going to be there, and this is very closely correlated to crime. And that's my main point, to say if somebody is in prison, it's very important not only look into substance use disorder, go and check for ADHD, because you have to treat both. And the recent literature tells us that both disorders have to be treated adequately, simultaneously, and also with psychostimulants. So and this is the next step we have to introduce in prison, because some people think it's going to be diverted, it's going to be too dangerous. But in order to have the better outcome, and in order to meet the human rights criteria, you have to treat both. And the analysis show you, if you treat both, you have a reduction in substance use disorder and a reduction in crime after release from prison.
Merci. Deuxième question.
Second question, hepatitis C, 45%, and they're positive anticopies, people who have substitution therapy. Do they have a treatment for that?
We all have treatment, and it's very interesting. I just recently was visiting Chisinau, looking into prison. They also have prison. Not 10 years ago, this treatment, the DAA treatment was very expensive, but now it's really price-wise, it's affordable, and it's even affordable for countries who are not that rich as my country, which is still one of the richest in the European Union. And we have a deficiency, we had a significant deficiency of diagnosing and treating hepatitis C. And I think that the main aspect is to make this available for the public, because it's also supporting the public health.
There's a microphone from the floor. Good afternoon. Simply I wanted to add to what you were saying a moment ago. We've also realized that there are a lot of people who go out released from prison with no support, people who leave on Friday afternoon, as you say. And we know that over the weekend, all the centers are closed. And so there's a lot of people who have to go and return to the black market to get the substitution therapy that they were having in prison. And this is quite the opposite of what we should really do, because that means that the person has to go into illegal resource points when they're coming out of prison.
My colleague from Sydney is going to be showing what a great option is having the depot product, because then at least it makes them safe for a few days. And what we actually want in the human rights section, what we want is that in patients who are not maintained on opioids, that there is naltrexone available for them for some days in case they don't find a treatment facility to protect them and not having deadly overdosing.
No more questions? And so I think we'll move on to the next presentation from Newcastle in Australia, and he's going to introduce himself now. And he's going to be talking about dépôt treatments in prison.
Merci beaucoup. Thank you. I'm going to talk to you about some research that we did using long-acting dépôt buprenorphine in Australia. Thanks, Fadi. There's my disclosures. And I'd also like to acknowledge the great research colleagues and clinicians that I work with that helped this work happen. The research was funded by New South Wales Health, the Department of Health. In the context, it's important to reflect on the Nelson Mandela principle. The context of this work is under-treatment of opiate dependence in prisons in Australia, which of course makes no sense, but that was the history going back to 2019. There was some methadone treatment in prisons, but if a person entered and was opiate dependent, they would not be given treatment until the end of their sentence. So they would only be offered sublingual buprenorphine treatment the last week before the end of their sentence. And of course, that's not good treatment. That's not allowing somebody to stabilise in treatment. The other significant problem was a very profound black market in sublingual buprenorphine in prisons. It was the most drug use, so more than heroin, more than methamphetamine, more than cocaine. It was the most drug used in prisons in Australia, and there's a very significant amount of violence associated with that. So violence in people trying to obtain buprenorphine. And just again to highlight, of course, opiate treatment is very effective in a custodial setting, and it's very effective in reducing overdose, fatal overdose and non-fatal overdose after release. It's also associated, of course, with decreased drug use in prison. So this study is just from our centre. It's a case control study of looking at patients released on methadone compared to sublingual buprenorphine in exactly the context I was talking to you about before. Patients who don't get the opportunity to stabilise on sublingual buprenorphine don't remain in treatment, and you can see that's exactly what we found. The blue line at the bottom is patients dropping out of sublingual buprenorphine treatment, and that's much more than patients staying on methadone treatment. So this study was a case control study over 16 weeks of a group of patients who were not on treatment, being given dépôt buprenorphine, so 4 weeks of weekly treatment and 3 months of monthly treatment. And there's a comparison group I'll talk about just briefly, but of patients already stable on methadone. So they're two quite different groups, a group not in treatment and a group in treatment. And the key outcomes were safety, adverse events, as well as retention data and drug use. So I'll show you those. It was a mix of prisons of different levels of security, of men's prisons and women prisons. So of the long-acting dépôt buprenorphine group, there were 67 recruited. The retention was very high, so over 80% at 16 weeks. There were no deaths. There were 2 serious adverse events, but they were not drug-related, including self-harm and an episode of rhabdomyolysis related to methamphetamine use. 4 people withdrew themselves from the study, and that was principally because they wanted to continue to get an effect from injecting sublingual buprenorphine. And the adverse event profile, so we saw more frequently adverse events seen in studies not in prison, but they were mild in nature. We looked very closely at diversion because this was one of the key outcomes, were patients trying to divert long-acting buprenorphine, and we didn't see any evidence of that at all. At the same time, I was saying to you before, there's a significant problem with diversion of sublingual buprenorphine, and of course, you know, in a jail setting, the authorities will detect a small proportion of the total amount of diversion that's going on. They continue to see diversion with sublingual buprenorphine during that period. So here's some data on self-reported drug use. You can see that at the start, the patients in the depot group were using pretty much every day regularly sublingual buprenorphine, illicit buprenorphine, and they were injecting that, and that dropped dramatically to at week 4 and at week 16 to about 5 days in the previous month. We also collected data on costs of providing treatment in prison. So there's 3 lots of data here. A group at the top is comparing depot buprenorphine and methadone and sublingual buprenorphine and looking at the healthcare costs, and most of that is staffing costs. The group in the middle is the prison costs, so the costs of prison guards, taking patients back and forth to have supervised dosing, watching the dosing, and you can see the comparisons again. If you add those 2 up, you can see that there's a significant advantage of depot buprenorphine, of long-acting buprenorphine over methadone. It's about half the cost and about a 10-fold difference in cost of long-acting compared to sublingual. And again, the key driver is staffing costs, prison guard costs, and healthcare costs. The medication costs, of course, methadone is the cheapest. It's been around a long time. It's the least expensive medication. And depot and sublingual are sort of equivalent, with depot being a bit cheaper. So there's 2 lots of data here, one comparing patients at baseline who are, again, remember, not in treatment, who were then given depot buprenorphine, and so their self-reported treatment burden was low, side effects were low, improvements in physical health was great, and quality of life was great, and in mental health was great, and they in particular reported treatment being more convenient. Here are some qualitative data, and I'll just summarise by saying essentially there were lots of reports of very positive outcomes, sometimes of patients who had never reported stabilising on treatment ever before. So they're, you know, anecdotes, but important to note that we were seeing people reporting some very positive effects, including this issue of not being exposed to violence because nobody else was trying to get them to divert their sublingual buprenorphine. Another key one was a decreased stigma by prison staff. So the prison staff, the prison guards, had a very negative view of methadone and sublingual buprenorphine, but when they saw patients doing well on long-acting buprenorphine, they had a positive view of treatment, which was not what we expected. And this gave some of the patients more opportunities, more flexibility, the chance to do work in prison that they didn't have before. We also did focus groups with health staff and prison staff, and similar findings that the prison staff were very, very positive. Of course, the healthcare staff were satisfied at being able to give treatment where they couldn't before, but the correctional staff were very, very positive about seeing opportunities for patients to get treatment. You know, so overall, very positive findings by all the groups that we looked at, and healthcare being able to provide it cheaper than options that were up to then. So this is a good argument to go back to the prison administration with saying it's important to provide this treatment in prison. We didn't expect the next thing, of course. Nobody was expecting a pandemic in late 2019, but it happened. And the result was that all visits to the prisons stopped. The cost of black market sublingual buprenorphine skyrocketed. It went from, say, $100 to $2,000 for an 8 milligram strip. The amount of violence escalated quite rapidly. There were riots in 7 prisons in New South Wales with prisoners rioting for treatment, saying, we want treatment, we need treatment now, we don't want to wait. And so the Health Department and the Department of Justice were sort of forced to respond to this very rapidly because of these problems. So fortunately, this study had just finished, and we were just starting to transition patients who'd finished the study to stay on long-acting buprenorphine. You can see that sort of around January, February 2020 was when the last patients were coming through the trial. The line in grey is the number on long-acting buprenorphine, the line in blue is the number on methadone, and the line in orange is the number on sublingual, and the y-axis is the number of patients. So you can see that the number on long-acting treatment overtook the number on methadone in the middle of 2020. The important thing to remember, though, is that the patients who were getting sublingual treatment were only getting it at the end of their treatment. Patients in long-acting were now getting it during the period of their sentence. So not only did the number of treatment increase, but the time people were getting access to treatment in prisons grew substantially. So currently, about 80% of all treatment is with long-acting in prisons. It's well and truly overtaken methadone. There's been about 3,800 patients released into the community on long-acting, and about 3,100 of those were commenced on long-acting treatment in custody. And it's been a reason that the number of patients in treatment has increased by about 20% in the province that I'm in. So we're now looking at studying what's the impact of patients being released on long-acting, and trying to better understand, is retention comparable to methadone? Is it as good or not as good? And there's reasons to think that it might be as good. The situation like before, if you're released on a Friday afternoon, you can stay in treatment, you don't have to worry about treatment on the next day. But there's also reasons to think that maybe it's not so good because, of course, you can stop treatment and you don't get an abrupt withdrawal. In terms of time, Fadi, I think I'll stop there and leave some time for the other speakers. Thank you.
Thank you very much. Des questions dans la salle?
Are there any questions? Thank you for your talks. I'd like to ask you, how is care organised in Australia? Are the teams in place? Because you talked about the cost of transferring the staff to accompany the prisoners. Are there in-house services like in France? And also the prison centres, how long were the sentences of the people involved? For what type of crimes?
Sure. So, on the first question, in most provinces in Australia, but not every province, the Ministry of Justice controls the prison and the Ministry of Health controls the healthcare in prison. The budgets are separate, but there's been much more money put into increasing the number of prisons than there has been into healthcare in prisons. So that's been a cause of tension and one of the reasons that there was not enough treatment before. The second question was about...
La deuxième question, c'était...
The speaker's not using a microphone.
So, yeah, in each jail there's a healthcare system that coordinates care in the prisons. Some of it's virtual care, so the medical care might be by video conference. The nurses are usually in the prison. Some of it's by visiting. And there's also good coordination between the centres in prison and the release from prison. So treatment is continuous after release.
Hi, Gavin Bart from University of Minnesota in the United States. I really have a question that ends up being ultimately for everyone on the panel. I think there's some terminology. I'm relatively new to criminal justice settings. And so when I think of criminal justice settings, there are sort of the jails of the pre-trial, where people may be there only for days, weeks, maybe months. And then there are the prisons, the post-trial, where people could be there potentially for years. Could you differentiate what setting it is you're presenting on? And if it's not both, I'm presuming it's prison, describe what is currently happening in the pre-trial jail setting, if anything.
Sure, thank you, and good question. And yes, there's different terminology used. And I'm sorry, the previous question was about what was the duration of sentence, and so the answer was the prisoner had to have a minimum of 6 months remaining on the sentence to be offered treatment, so that we could see the effects of 4 months of treatment in prison. And the treatment was continued after the 4 months, so it didn't stop at 4 months, but that was the criteria for being offered the medication. So sorry, it's used interchangeably in Australia, and I understand that's confusing. This was done in populations with people who had long-term sentences. There might be different parts of that prison that's like a jail, so it's for people awaiting sentencing. So there were 7 jails, and they really are quite different jails. So some are high security, some are low security, some have a mix of non-sentence and sentence patients, but this study was for people who already had a sentence.
C'est dans le cadre de cette étude.
You said this in the framework of the study. Whether they receive treatment in the prison or not. You said that currently it's a study. It's a study. But those who are not in the study, are they subject to treatment? Do they receive treatment? Those who are not in the study.
So now, yes, who are not in the study receive treatment. Back before, if a patient was on methadone, their methadone was continued. If they weren't on methadone, they would not receive treatment until the week before they were released, and then they'd be offered treatment, but that's not really treatment.
Just a question. In Australia, is healthcare in prisons, is it part of the Ministry of Health or Ministry of Justice? Who is the financing party?
Pas d'autres questions? Non?
No other questions?
Thank you very much, Adrian. Thank you for telling us about the Australian experience. And now we're going to move on to in the workshop. We're having a discussion, a round table around harm reduction in jail in France. And I'm very proud to welcome Caroline Protet. And we're going to be showing you a few slides about risk reduction in French prisons. And then I hope that we will be able to have a discussion about this together. So if you'd like to present the slides. Thank you very much, Fadi, for having invited me to this workshop. I'm Caroline Protet. I'm a sociologist, and I work in the French Observatory of Drugs and Addiction, and I'm a reference for studies in prison. So Fadi is going to begin the presentation. When we're talking about risk reduction, this designates all of the strategies which are designed to limit risks and health or social damage which could be linked to a specific domain. in medicine, when we're used to talking about cardiology and diabetics and pneumology when we reduce risk. But unfortunately, it's much less frequent when we're talking about people who have substance use disorders. And we're used to working in factories and buildings and so on. But there can be risk reduction policies. So we could see that there can also be collateral damage. In prisons, why do we have risk reduction in prison? Because there were still doubts. Some people still had doubts about drugs in prison. But now, over the last 4 years or so, I think, France has agreed, like some other countries, that you could analyze the wastewater coming out from prisons. And this analysis showed very clearly to the institutions and the ministries that there were drugs in prison, that there were all the drugs in prison. You could find heroin, cocaine, cannabis, and substitution drugs like methadone or Buprénorphine. But this was in the wastewater coming out of the prison. So perhaps it's not only the prisoners, could also be other people in the prisons, perhaps the medical staff or perhaps the penitentiary staff. But this said, the doubts that we had, there were doubts also about practices of drug taking in prisons. What happens in prisons? Do people smoke in prisons? Yes, but people also inject in prisons. Even the local media say that when there are searches in prisons, in the cells in France, then people find syringes when they do these searches. So the question of injection in prison is not one that concerns only France, because you can see all the other European countries are also concerned by this issue. So I'd like to continue, because on the question of drug use in prison or substance abuse, the question of what are the percentage of people who are actually using drugs, we did a review of the literature on the question, which was published, I think, in 2019 or 2020, I can't remember. I wrote the review of the literature, but I can't remember exactly when it was published. But you can see that the difficulty in France is that the data that we have are very disparate. They're not national data. Sometimes they're data that we have which can be either regional or just with one institution. And to a certain extent, it's very difficult to show any national predominance data. We have a current research program in progress to try and establish national figures, and the data will be available at the beginning of 2024. But to begin with, what we can see on this table, which shows the available data at the moment, in terms of the general population, the adult population, the consumption of cannabis is about 10.6% of the population. Cocaine is about 1.1% of the population, and heroin 0.2%. And if you compare that with the surveys that were carried out in prisons, for cannabis, we're up to 35 to 40%, cocaine 10 or sometimes 2%, depending on studies, heroin between 1 and 8%, and medication which is abused from its initial use is between 10 and 15%. So we're much higher than the figures for the general population. And so the wastewater survey that you just heard about, even though it shows that it concerns all the people in the prison, including the medical staff and the prison wardens, but the estimate is that approximately 2.7 joints per day per person in a prison. So we have levels of consumption which are 10 to 20 times higher than in the general population, which is pretty impressive. So concerning the forms of administration of products, we can see that there are modes of administration which change. Injection remains, not necessarily injection of heroin. I think Fadi can mention that, but the most often injected substance in France is cocaine. So this is something which is important to emphasize, because sometimes you connect injection with heroin, and that's not necessarily the case. Sniffing concerns probably 3% of prisoners. And in prison, there's a change in modes of consumption, particularly for certain prisoners, moving from injections to sniffing. or to smoke, and transfers of consumption, particularly going from drugs other than cannabis to cannabis or to medication which is not used in its usual medical context. So I hand over to Fadi again. Now, the law, what does the law say on risk reduction? First of all, the Convention of 1994 talks about equivalent levels of care that you should have in the prison as equivalent to what you could get outside. And that's next year. That will be 30 years since this law was published, but we still have not yet respected the mission that we were given. That is to ensure that you can have care which is equivalent to what you would get outside the prison. The second law, which is interesting, which is a decree 2005 on risk reduction. It's the first decree to apply the law in France. It's 2005, and the question was that you could go wherever you could to carry out risk reduction. Wherever there are risks, you could carry out risk reduction policies. So you could go to see people in streets, in parkland and so on, in cities. Wherever there's a risk, we have to go and meet the patients and reduce the risks. Also, the penal law or the prison law of 2009 on equivalence of care. And 2016, there was a law here which is no longer the 2014 law, but a law which is a health law, which says that there must be risk reduction in prison environments. So what was the blockage? The blockage is that there's never been a decree to apply, to enforce the law. The law has been published, but not the decree which actually applies it. And currently, the legal profession agrees that if a law has been voted, if there's no decree, then it can still be applied by default, as it were. And there were low-risk consumption units, and these needed to be in health services in prisons. When care people know that, and when they give equipment to people who take drugs, they cannot be pursued, they cannot be taken to court for doing so. So it's up to the state to apply the law. The first decree applied in 2016, it wasn't actually applied because the prison administration wanted patients to request to make a request to the director of the prison so they could inject, and if the prison authorities gave that authorization, they could inject in the health services. And there was a certain refusal with a rejection of that. But now a research body has been asked to draft a new decree, and the Ministry of Justice and the Ministry of Health have still not come to an agreement as to what they're going to decide between the two ministers. If the two ministries don't want to agree, then the Prime Minister will decide whether that decree should be applied or not. But I'm talking about the decree of 2005. It says that you have to go everywhere where people are at risk. But now, in terms of risk reduction, what is risk reduction in prison? We have a document here, the ODC, which is a United Nations body ratified by all states, including France, that ratified this document. And the question is that there should be a complete kit of risk reduction. And here you have the 15 key points here, including the prevention, issues connected with tattooing and so on. And the program of syringe exchanges is one of these 15 points that was voted. So what is going to be updated now, and there's an update that's coming out shortly, the question is to add nicotine substitute analoxone and PrEP, and gender-specific issues, because there are women, and we're talking about crack pipes and so on, and also groups, focus groups to discuss this among users within the prisons and so on. This morning we talked about long-acting Buprénorphine. We know that for people leaving prison, when they have this injection, it gives them a month outside prison where they don't have to, there's no risk of an overdose connected with the use of opioids or heroin if they are under long-acting Buprénorphine. What about the costs? and the way that risk reduction is applied in French prisons. First of all, just look at what happens elsewhere in Europe. In Europe, there are a lot of risk reduction tools which have been shown to be effective scientifically. The assessment, information, delivering substitution therapy, psychosocial interventions, preparing release, programs for syringe exchange, and access to naloxone. And these different tools are used to different extents in different countries. There are only 5 countries which provide access to naloxone in 2018: Estonia, France, Norway, the UK, and Germany. And only 4 countries proposing syringe exchange programs: Spain in all prisons, Romania, and Germany and Luxembourg in some of their prisons, or sometimes just one prison. I think that's the case for Germany and Luxembourg in particular. So you can see that despite the fact that the effectiveness of a certain number of tools has been demonstrated, Europe is still behind in terms of using these different tools. What happens in France? Recently, the office had to study a survey that was done by the Health Ministry, and we have exploited this data to draft the decree after the 2016 law. The General Direction of Health ordered a focus group, and we've had a certain number of meetings with health units to see how they applied this and how they used the different risk reduction tools. The Ministry of Health survey showed that in 55 prison establishments, and there are 197 in France, there were various addiction care centers which provided naloxone kits. In 4 prisons, distribution was done only during prison periods, whereas 11 sites also gave kits on release of prisoners, and that's extremely important. For syringes or injection kits, these are available in 11 prison establishments through the various care units that are involved in prison care. It's mainly the XAPAs. There's different types of care units that intervene in French prisons. But there's a lot of work done in this direction. In 9 prison establishments, one of these care units provided crack pipes or inhalation kits. This is very interesting. This survey shows that there are more exchanges of syringes which are set up in French institutions than distribution of inhalation kits. But one of the elements that the focus group showed was that their ways of distributing syringes was very different from one institution to another. Some set up some distribution centers with syringe exchange centers with 2 syringes or 1 or 2 syringes. Other institutions distributed syringes in units, or when the patients came in, they gave their used syringe, and in replacement they were given a new syringe, and that the prisoner could then take in a little tube to protect the syringe. So there was a kind of setup of a syringe exchange program, which are very different from one institution to another. And coverage, there were some health units who distributed a lot of syringes, where others distributed very few. So there's different coverage within units. So how can you explain these differences? First of all, because the staffing of these units within the prisons can be very different. And you can sometimes have a dedicated team with a care unit within the prison with dedicated staff, or it may be just 1 or 2 people who are part of the reference center and who come in 2 afternoons a week. So depending on the staffing, necessarily you cannot apply the risk reduction methods in the same way. The second reason is very different representation of risk reduction for drug users in the professionals in the healthcare units within the prisons. And what we were able to learn is that there were teams where risk reduction was very well perceived and drug users were not stigmatized, whereas in other teams, the question of risk reduction was very divisive amongst the health professionals, so sometimes with an ideology of abstinence in prison and some reluctance to distribute tools which it would enable prisoners to use psychoactive substances. So that's something which was particularly clearly shown when the health units depended on the old system with sometimes different conceptions of what risk reduction really meant. And finally, there's very different appropriation of risk reduction in France could be linked to difficulties of access to the prisoners. Not everybody in the focus group, they all said this. I think everybody who visits prisons know that drug users in prison are extremely stigmatized. And the simple fact of going to get your substitution at the care center can lead to stigmatization. So there's a significant taboo with the professionals when it comes to recovering or distributing material to enable the prisoners to take their drugs. We have a few recommendations after this work. The first was that we should increase the staffing in the care centres, care units within the prisons. Of course, that's an obvious thing. The second thing, we spoke with Fabio about this recently, is that we should have a team project. And it shouldn't be just one or two health professionals who would come into the unit from time to time, but that risk reduction should be part of a project. And then there was a question of continuous training of professionals in the health units involved in prisons and their colleagues working in the health centres and with the prison staff, including the management of these prisons, and also the idea of making much more widely available the tools of risk reduction and have a constant provision and a constant review of risk reduction. For example, using the tobacco-free month to have a discussion about risk reduction with regard to tobacco and also the other substances taken by the prisoners. Those are the recommendations that we made at the end of our study. Thank you very much. The work is not over. We've been having work groups year after year. And every time we send in a report, it goes into a drawer somewhere, and we start the discussion again later. Are there any questions from the floor? Somebody want to tell us something about what they do? Good afternoon, Charles Aubry. I work in the prison in Lorient in Brittany. I can see this syringe exchange system is something which is pretty, is rather hidden, and sometimes they do this very, very discreetly. And I'm very uncomfortable. I know that my colleague who did this has left and handed the baby over to me, if I can put it that way. Sometimes I've had problems with the legal authorities with regard to these syringe exchange programs. I have 2 or 3 patients I provide syringes regularly, and for I don't supply equipment. I exchange used equipment and material. And the first thing that I exchanged, there's somebody who'd recovered a syringe, and he'd kind of tried to use a cotton bud, which I think encouraged the risk of infection. I think that I'm in the right when I'm doing this, but it's always extremely complicated. You need to justify yourself, even with regard to the professionals within my team. It's extremely difficult, extremely complicated, and difficult to actually implement, to have these syringe exchange programs. Thank you. I think it's been for 12 years now we've had a syringe exchange program, and we give a complete kit. I'll show you a photo. The management officially wrote to me, and I've kept the letter. The management asked me formally to stop this syringe program, and I said that he had no right to get mixed up in our affairs, and I wasn't going to take any notice of what he said. We've been doing this program for over 10 years. We've never had any incidents. We've never had anything happening, any kickback from the administration. They'd like to stop it, but they can't. We are in a situation where there's a law and no decree, and the prison administration cannot prevent us from doing it. They cannot forbid us from doing it. So I think you have to dare to do it, and you have to go ahead and do it. I know there have been issues in Brest, in Brittany, with the administration trying to put pressure on one of the doctors, but it didn't go very far. In Lyon, too, there was exchange of syringes, but again, there was pressure from the administration, but it didn't go any further. And I think there have been other places where there's been somebody, a prisoner, who said that his co-cellmate was injecting, and this went up to the ministry, and there was a lot of noise made about that, but it stopped there. But I think you can't do anything against a health professional who has a syringe exchange program implemented. You can see the ambiguity there, because in your slides, when you talk about the European countries where there are the syringe exchange programs in Europe, you didn't mention France. No. Officially, no. But what happens is that Spain is the only country with a syringe exchange program which is official, and it's run by the prison administration. If the person, when they come into prison, say they inject, then they're written on the list, they're registered. And in Switzerland, there was only one canton in Geneva, which had a center that was open, and that was official again. In Germany, it was just one prison, and I think they've stopped doing it. I think you have to go to Kyrgyzstan or some other countries like Iran, where there's not much substitution therapy and a lot of injectors, so they've set up this program because they needed to deal with the problem of infection. There are very few places. There's Luxembourg, but there's just one prison. And in France, as it's not official, I put in the countries where the program was official, because generally these were experimental programs, but they're official. So what's interesting, though, is, and I think we discussed this with Fadi recently, very probably, as it's not official in France, there must be more health departments that practice it than actually declare it in the survey, because it was a survey for the official administration, so they probably didn't let on. But I think what Fadi was saying a moment ago is that the other prison establishment which we asked about their syringe programs, who distributed Stereobox just like outside prisons, very officially, they have exactly the same argument. They say to the administration of the prison that risk reduction is care. And if it's care, then the care department can implement all the tools necessary to carry out healthcare within the institution. And the prison administration has no way of influencing healthcare in a prison. And there's an article in the medical deontology code, the Code of Good Medical Practice, explaining that any care professional must provide care to any person who needs it. I think you quoted that at the beginning. I think that professionals who practice syringe exchanges have support in the texts. Once a law has been voted, you don't need an application decree. It's the Ministry of Justice who asked for a decree, so that prison administrations have a kind of special role in that. But the law can be applied as is. So that was just a clarification with regard to the question of the various countries. I'll just show you a few photos here of the syringes that we collected at the time. And even recently, you can see it. When you see a syringe like this, which was being used several times, and as it was leaking, they really tried to block up the leakage so they could use it. You could see the blood that's in there, and the needle has been used several times. And you can see the state that it's in. So you can see that there are syringes in prison. And what we are implementing it's this kind of kit that we have, and this is what we give to the patients, and they leave with that. It's good because these kits have written on them distributed by the health ministry. So that's to say that these are official kits distributed by the health ministry. The patients leave with them, they come back with them. There is no incidents since we've set up this program in this way. Question from the back. Elise Meunier from Brussels. I just wanted to say something about what you were saying earlier. It's very important, the question of what are our rights, and that this is not simply for healthcare professionals, something which is personal commitment, and to dare confront the pressure that's put on them in this environment. And there's also a problem of ignorance of rights that we have. And I think that it would be very helpful if we could disseminate the information that you've just given on the fact that we can't be bothered if there's pressure from the administration. They have no right to interfere. And so that you can be aware of that and be sufficiently comfortable to react to pressures which can sometimes be pretty pernicious. Yeah. Question from the front as well. I just wanted to ask you, where do the figures come from? The percentage of drugs circulating in prisons? What I showed, there are several surveys. There's a survey that was carried out by the health center in Lyon, I think, and the most recent one is in the Loire Valley, the Cosmos survey. So there are various surveys. Yeah, the figures or the focus groups? Yeah, the figures come from various regional surveys, mainly anyway. That's what I said. I said there were figures that was regional or based on one individual institution. But the national survey will be coming in 2024, and you'll have fresh data. I think there were a couple more questions here. Pierre Crépin from Gaia in Paris. Risk reduction in prisons. I think there are a lot of situations where there's privation of liberty in, for example, healthcare in isolation, for example, or in psychiatric units which are closed, where, as far as I know, in risk reductions, there's a need there too. And these are just where it does happen. It's personal initiatives of providing syringes. It's much more open than in a prison environment, but do you know if there are any risk reduction systems officially in those other environments where there is a privation of liberty? Is risk reduction implemented, and do they has risk reduction been identified in those institutions? Now, that's a very interesting question. What we do know is that in psychiatric hospitals, people who have addictive issues, heavy addictive issues, unfortunately, depending on how long they're going to be spending in there, they're not always supported. But this is something which I would have liked to have been able to research. I've worked in mental health for a long time, and we saw there was a kind of rejection of patients who had addiction issues, but including cannabis use. But we know how much psychoactive substances, other than those which are prescribed by psychiatrists, do raise problems in healthcare units, particularly when they're closed units. But unfortunately, I have no data on that, but this certainly would be a very interesting survey to carry out. I don't know if you have any data. Nope. If it's not official, we don't have data, and it's not something we can really talk about. Just take one last question and then move on to the next presentation. Mine from Nancy and the prison of Nancy. My impression is that the more you move in the direction of having syringes and so on, like condoms and so on in prisons, I can understand the discourse saying it's legal and they can't stop us. But there are a lot of problems with reprisals from the prison administration, which, for example, won't open the prisoner's cell so that they can go and consult. Last week, for example, I had a case with a patient. It took us 4 hours to get to see him because they didn't want to bring him down. We had to call the director. They didn't want to remove his handcuffs. We had to call the director at her home. And the more we try to set up things to treat people and care for people, this is healthcare, the more we have reprisals, in inverted commas, which are not legal reprisals, but the patient is not sent down. Sometimes we have to write a number of letters to get them to open. I'm a nurse. I can refer, but I don't have any power to say, yes, I'm here to care for this person, and you cannot refuse access to healthcare for that person. And I don't really have a solution. I'd like to know what your view is on that question. I don't know. I've got a colleague in the room. I can't see the back of the room, but I can tell you, for example, that at the moment, we distribute about 15 or 20 crack pipes per week, 15 to 20. Syringes, I don't know, if some time ago we had maybe 10 syringes a week or 5 for one pipe. Now it's the opposite. Some 15 crack pipes for 2 syringes. We continue to do this, but there's always been, and there will always be, patients who don't come to consult and say, I wasn't allowed to get in, they didn't open my cell. There are always something like 15 to 20% who don't come. But we tried to carry out surveys to say why people don't come. We didn't realize why 15 to 20 people who don't come to the consultation, maybe they didn't want to come to, maybe they preferred to do something else. They had an appointment with their lawyer or whatever, or they had a sports time. This is one of the stumbling blocks we have in prisons. But the development of risk reduction tools that we have set up hasn't reduced the number of people coming into our consultations. We don't have less people coming to see us because we have the risk reduction. But I think what the focus group showed, that the more communication there is with the prison administration, the more the health unit is free to act. So among the recommendations, we talked about training, but in a very broad sense of the word. It could be 1 session a year with the prison staff. But once again, including the management, I think that's extremely important to make the management aware of these issues. Of course, it takes time. Sorry, no mic, can't hear. I can't hear. She's not using a microphone. My feeling is that this is the right route to follow, whatever it was. You've answered the question that I was going to answer. And what about the prison staff and all that? Training, awareness, and so on. So thank you for having answered that question that I wanted to ask. Unfortunately, we've carried out a lot of training schemes, but with the turnover that you have, if there's only like 5 wardens who come in when we have a training program, it's very complicated. And until nationally, or in the National Prison Administration School, there should be something that should be an opportunity for us to go and explain what we're doing, and we could do hours of training when the wardens come into the prisons, and they should be aware that these things exist before they actually start working. But when they're working, there's always a problem of absenteeism. They don't have time for the training. It's very difficult for us to set up this kind of training course. And I've done training for the staff, and I could say, yeah, we've done 3 or 4 courses, but it was 4 or 5 people each time. And I hardly dare say that it was actually a training course, even though for the prison administration they say, yeah, we've done a training course, and they can tick the box and say we've done training. But the 4 or 5 people who were there, I don't consider that I've really carried out a training program for the staff. I think we have to carry on because time is going by, and so I think we have Iran and Ukraine. I certainly invite you to stay because I think it's a very important story. We're not just remaining with what we have in France. Elie AARAJ, who is the executive in the Middle East, and he was responsible for infectious disease and particularly in the questions of stigmatization in Middle East and North African countries, and he's going to be telling us about his experience.
Good afternoon. I'm delighted to be here this afternoon. I'm not here to present a study. What I'm going to present is rather the facts about a situation in an area which has been living under a volcano for years. We talk about the situation of prisons, as you know, with what's happening at the moment in Gaza and in southern Lebanon. It's very worrying indeed. I'm going to speak in English.
To start, MENARA is the Middle East and North Africa Harm Reduction Association. It was established by WHO Regional Office Initiative in collaboration with Harm Reduction International, with the support of Drosos Foundation and other partners. The establishment was in 2007, and MENARA is currently registered in Lebanon as an international NGO. This is a network of civil society organizations and individual experts and professionals, community members working in 20 countries in the MENA region. The MENARA is mainly based on the MENARA's objectives and work is mainly based on enabling environment, all the work related to advocacy, all the work related to supporting the decision makers to somehow adopt harm reduction strategy, but also to maybe work on a policy reform towards more human rights and people who use drugs rights. We also work on capacity building for civil society, but lately we started supporting the governments in kind of technical assistance. We trained all the healthcare providers in the governmental hospitals in Egypt and last year, and they started the methadone provision in last March. Currently, we are preparing to develop guidelines for OST in Jordan and in Tunisia, in addition to the training that we will do. We have a group of religious leaders, Muslim and Christian, who are becoming allies for us, and also a group of law enforcement. At the end of November, we're going to the League of Arab States, trying to do all this kind of capacity building, but also advocacy in order to, for example, revitalize the Arab strategy on AIDS. One of our main also activity is to empower the community-led organizations. Currently, we are supporting a group called MENANPOD, the MENA Network of People Who Use Drugs, and they are getting registered also in Lebanon as an international NGO. In the region, you need to know maybe that there is a lack of transparency. We can't find data. We don't know what's happening in the region. We don't, as we always said, we don't know our epidemic. There is no testing as it should be. And the governments do not report to WHO or to other bodies about their epidemics. Although currently we can find that this is related to political sensitivity. They don't want to show that they have problems in some countries. They prefer to say that these are the foreigner workers who are working in our countries. But on another side, we can see that some of these countries have started to include some harm reduction activities in their work. This is, we can say, about the inadequate monitoring. We don't know, as I said, but also there is a big problem is that, for example, UNAIDS has closed the regional office in MENA. So this slogan who said no one left behind is not true, frankly, because they closed their office in a region where you have an increase in the prevalence, and it's a region where you have the less coverage in services, be it harm reduction, be it ARV, or other kind of services. Also, the legal system is a little bit rigid. In the region, we have around 6 countries that still have in their laws the death penalty for drug use. We have very restricted laws, although they all have rectified and signed the unique convention of 61 that consider a person who's using drugs is sick and is not a criminal. And the level of stigma and discrimination is very high. And as I mentioned at the beginning, the current security situation is very alarming, and it takes the decision makers to other priorities rather than discussing issues related to drugs and to HIV. The majority of the prisons in the region are still under the Ministry of Interior Affairs, which means it's under the Internal Security Forces management. And this can be translated in the behavior. When they work with these people, we can't find that this is, for them, it's a kind of rehabilitation or social and professional reintegration of a person who is detainee. It's mainly about sanctions and not other issues. In Lebanon, as you might know, before talking about the prisons, Lebanon is going through a very severe economic crisis since 2019. It was topped up by the COVID, then the Beyrouth blast, and lately the security situation in the south. The people of Lebanon are living somehow more than 80% under the threshold of poverty, and the prisons are one of the institutions that were affected by this situation because, as I said, there was a lot of problems that can hinder their well-being. So, as I mentioned, there is no services in the prison. It's under the internal security forces, and the problem, the inflation and the economic problems led to a decrease of the salaries of the employees, the governmental employees like the police officers and others, but also the judges and the lawyers. And this is how last year we faced around 1 year of lawyers' strike, and followed by around 6 or 7 months of the judges' strike. And lately, the medical doctors at the prisons are living a strike because for them, they cannot continue to have only $60 a month and to go spend the days at the prisons. So this is one of the situation. In Lebanon, we have in total around 25 prisons. The number of prisoners is 6,200 prisoners, while the prison's capacity is only 1,400. So it's overcrowded. The number of people who are in detention facilities outside the prisons, I mean at the police station, is around 2,000. Because there are no places at the prisons, but also because there is no the judges were striking, so there were no procedures. Of all inmates, only we have 75% of them. They are at the pre-trial detainees situation, means that in process they didn't get to the process, and 25% of them were convicted as a prisoner. I need to add here that among the juvenile prisons, we have 60% of the young people or the minors who are from the Syrian nationality. So the challenges are first, the prisons are crowds, and they are taking 4 times more than their capacities. Inadequacy in healthcare access for a person who is on Buprénorphine. In Lebanon, we have the Buprénorphine. If he's being incarcerated, somehow by a gentleman agreement, if the officer accepts, he or she has the right to continue their treatment. If the officer doesn't accept, they don't have the right, because it is not written in the not in the strategy nor in the law. So this is a big problem for them. In addition of that, there is a big problem because also the internal security forces are lacking from resources. And since few months we started knowing that every second week maybe we have someone who died in the prison. Why he died? We went to the police, we asked them, are you torturing them? They said no, but we don't have fuel to take them to the hospital. And if we have fuel to take them to the hospital doesn't accept them because we don't have money to pay the hospital. So this is a big corrupt system, if you want. We cannot blame maybe the internal security forces, but we can blame the system because it's a corrupt system in general. There is no human rights sensitive services in this country. This is, I mean, the mental health problems also, there's no services on mental health and a lack of specialized care providers in the prisons. Only during the COVID-19 period, they took some measures to accelerate the process of the court. For example, they had a court in the central prison, but also they had investigation online and some mental health services online. After that, everything was closed. Okay. So the Lebanese prisons face a high incidence of infectious disease, be it HIV, tuberculosis, or hepatitis. The overcrowding and the insufficient health care contribute to disease transmission as well. We have inadequate prevention and treatment. Inmates often lack access to preventive measures like condoms and other kind of preventive measures. And limited treatment options contribute to the spread of these diseases within prison walls. A few months ago, we were called by a group of NGOs. We built a task force to support the prisons. First, we were informed that the caterers will not provide the prisons with the food because the government is not paying them. So they asked for an emergency fund. Then this was somehow solved by the government, between the government and the caterers, but now we have the problem of health. So again, an emergency fund now is built, trying to find money to support here and there, a scanner here, operation there, etc., surgical operation, I mean. So this situation is very bad for us. Although Lebanon has signed all of these international agreements and the human rights, etc., the recommendation is to improve healthcare access, to increase funding for healthcare services in prisons, and the ideal is to shift the responsibility from the Ministry of Interior Affairs to the Ministry of Justice, and to have somehow an involvement of the Ministry of Health in these prisons. To address the overcrowding, the issue is to accelerate the process of the judgment, and some people can go home and wait for their their judgment sessions, and to have some mental health services. For us as a Menara, we suggested to the government to develop a health strategy for the prison that can work mainly on the existing resources like the Ministry of Interior Affairs, like the medical student of the Lebanese University, etc. Until now, we are under negotiations. I can stop here. Thank you.
Merci beaucoup. Merci beaucoup.
What I now propose is that we will going to continue with the account by Yanina. I'm very proud that she is here with us today. I met her 3 or 4 times in Georgia on a program where we're working together on access to healthcare in Russian and Ukrainian prisons, which is even worse now during the war. So I'm very happy that she's able to come from UK. She's going to talk in Ukrainian, but there'll be a transition to French. So thank you to Julia for translating for us. It is indicated in his case file that he pleaded guilty in full. Today, I'm here to talk about the harsh realities of the Ukrainian parliamentary penitentiary system. Good afternoon, dear friends and partners. My name is Yanina STEMKOVSKAYA. I've been working in the field for many years, and I know for a fact that medical care, and especially substitution therapy, has traditionally been used in the system as a form of blackmail and manipulation. This is a cruel and unfair practice that needs to be stopped immediately. Today I want to tell you about Serhi. I'm trying to unsuccessfully support the situation of prisons. I would like to tell you about the story of Serhi. He was detained on suspicion of theft and held in a police station for several days in a state of severe withdrawal syndrome. The investigation was unable to prove Serhi's involvement in the crime, and then he was offered a deal. He'd be released if he assumed responsibility for the possession of weapons, 5 grenades that he allegedly found in the woods. The police assured him that he would only get away with an administrative penalty, and Serhi agreed. Instead, the police opened criminal proceedings. The Court of Appeal upheld the verdict and so was taken into custody. He was sentenced to 3 years of imprisonment to be served in a high-security penal colony. In all the case files, it was stated the man pleaded guilty in full. In February 2020, the Court of Appeal upheld her verdict and Sergei was taken into custody right in the courtroom. It was only on the man's 3rd day in pre-trial detention that he was examined by a narcologist. Sergei was prescribed what's called detoxification, 5 days of taking methadone with a daily reduction in the dose by 10 milligrams. After this treatment, the doctor recommended taking neuroleptics. After a few days, Sergei was left without any medical care in a state of withdrawal. This approach of Ukrainian prison narcologists who carry out detoxification in 5 to 7 days, designed to gradually reduce the dosage over several months, can be compared to torture. In a state of withdrawal for a long period of time and in endless pain, Sergei has lost what remains of his health. He is currently serving his sentence in a penal colony in Ukraine and refuses both legal and social assistance. He has lost faith in the possibility of asserting his rights and does not argue with the administration out of fear. Here is a second story in which we're able to achieve positive results. The beneficiary asked me to help him arrange treatment for hepatitis C. Due to the fact that he was serving a life sentence, such medical care could not be provided to him. According to Ukrainian legislation, you can only receive treatment for viral hepatitis, as well as many other treatments, through a referral from one's family doctor. Signing the declaration with the family doctor is part of the medical reform and gives every declared patient a wide opportunity to benefit from free medical services. Unfortunately, such a service is not available within the system of the Centre for Health Protection of the State's Criminal Executive Service of Ukraine. Prisoners have no legal right to access the services of family doctor and other consequences to various types of treatment for many diseases. We have repeatedly appealed to the Regional Centre for Health Protection of the State Criminal Executive Service of Ukraine and even to the Ukrainian Ministry of Health. However, it was only through the court that we managed to obtain a positive decision for 3 lifers. They were allowed to conclude a declaration and receive treatment for viral hepatitis C on an individual basis. Unfortunately, this is an exception rather than the rule, because medical care in prisons, while remaining under the authority of the penitentiary system, is not only of low quality, but very often is based on blackmail. In order to receive quality medical care, you have to fight, often through the courts, to obtain right to treatment, which always causes negative consequences on the part of the prison administration for the prisoners. They often lose their health during these long periods. The following story is about Victoria. She had a genital pathology. Victoria suffered from incontinence and had to wear adult nappies permanently. She received no care, and due to chronic hypothermia, she developed acute bronchitis requiring drainage. This was done without medical treatment. Despite her critical state of health, we were not able to obtain her release for medical reasons because no reliable diagnosis had been made by a doctor for her illnesses. She was unable to work, which closed off the possibility of release on bail. Despite everything, thanks to legal assistance and very long procedures, we have finished by obtaining her release on parole and getting substitution treatment for her outside. She also now receives care for her other illnesses. Finally, Alexander is a victim of police brutality. He is currently carrying out a sentence for drug trafficking, for which the Supreme Court of Ukraine has observed incoherences in this criminal case and sent the affair for a new hearing. But the new court hearing did not pay attention to the conclusions of the Supreme Court and left the verdict unchanged. In order to justify the invariability of its decision, the courts based their decision on certain witnesses, and they cooperate with the security forces. In the inhumane conditions of the Poltava prison, where water runs along the walls and the ceiling is falling in, and there are insects which live, Alexander's kidney infection has got worse, and he now has blood in his urine. He was in such bad pain that he was biting his hands and screaming. He never received any care. We presented his case to the European Court of Human Rights. But the war began, and for reasons independent of our will, the request was never made, since we were outside the legal deadline. Nevertheless, Alexander is continuing to reclaim his justice and wishes to take those responsible for criminal inaction, preventing him from receiving care. Alexander is preparing to be released in January and is already in his hometown on a substitution program. The dysfunctioning of penitentiary medicine are an issue which can be neither ignored or underestimated. Prisoners don't have access to medicines, independent medicines, doctors, or to appropriate medical care. These practices lead to torture and dozens of deaths. I'm Yanina STEMKOVSKAYA. I have experienced incarceration and have the right to speak in the first person about defending the rights of other prisoners. I'm here today to say that prisoners should have access to decent health care independent of the penitentiary system. This independence is necessary to guarantee appropriate medical care and independent medical expertise, which they need and they deserve, without worrying about manipulation or blackmail by prison officers. Are there any questions about the last two presentations? It's not easy to ask questions, I know, after hearing the last talk. And I'm very proud and happy that Yamini has come here to be out. We've been talking for a while now. Ukraine has decided to provide put healthcare under the responsibility of the Ministry of Health, those in prison under the Ministry of Health. We hope after the war, I'm not sure whether it is during the war, but today in Moldavia and Ukraine in 2024-2025, they should work on transferring healthcare from the Ministry of Justice to the Ministry of Health. Is that still on the agenda? This reform began 2 years ago with the war. It has been, it's a slowdown, and with a dedicated budget, which of course is reduced because of the war. And so this is also being financed by international organizations, but it's a work in progress, but it's been slowed down. And there's a first stage of the reform which was implemented within the Ministry of Justice, which is providing healthcare. The idea is to completely transfer healthcare from the Ministry of Justice to the Ministry of Health. Thank you for your account about Ukraine. I had several questions to ask. The first, is the situation that you describe, is this similar in all the different oblasts of Ukraine? The second question, I wanted to know if the situation in terms of reducing risks in open environments. I work in a French association called SAFE, and as a former humanitarian worker in Ukraine, for reducing risks, it's said that the programs are working and that we don't need to provide syringes for reducing risks. Is that true, or are there really needs? Thank you. The situation described concerns all the regions of Ukraine, even the cases she's presented. The programs for reducing risks in Ukraine are working. I'm part of a risk reduction program. It works, but let's say it's purely about giving pills. That's about it. In 17 years, I've had 3 interviews with a social worker. We also have syringe exchange programs. In theory, it works, but Ukrainian legislation is so harsh that if you are found with even a minimal quantity of drugs, then they confiscate the syringe with the drugs in it.
You could be in trouble.
There are also peer-to-peer support programs, but the quality is not always great. Are there any other questions? Thank you to Julia for your translation from Ukrainian. Again, I'd like to thank all the speakers for being here and for staying so late.